You can. Okay. All right. All right. Here we go, guys. You ready? Welcome to this presentation in recognition of Lung Cancer Awareness Month, Turning the Tide on Lung Cancer in the African American Community. I'm Dr. Susan Chandler of Massey Cancer Center's Integrative Health Program. And in collaboration with Massey's Office of Community Outreach and Engagement, we're pleased to bring you what we believe is an outstanding presentation about tobacco, how the African American population was targeted early on with menthol products, and what's being done both on the national stage as well as in our own communities to correct this travesty. With us today are two experts in very different specialties, but with a common goal of turning the tide on lung cancer through their expertise, dedication, and of course, the work they do. Rashelle Hayes, Ph.D., is an associate professor of psychiatry and psychology here at VCU, and is also trained as a licensed clinical health psychologist. Her clinical work at VCU includes both working with and patients to help them quit smoking within our cancer center, and also in helping patients manage their weight and cope with chronic medical illness. Her research interests are primarily in developing and testing smoking cessation interventions among cancer survivors and minoritized populations. She's excited to join the conversation today, as we are excited to have her. And then we have Alex Krist, who is a medical doctor and also holds an MPH. Dr. Krist is a professor of family medicine and population health at VCU also. He practices and teaches in Northern Virginia, and he directs the Virginia Ambulatory Care Outcomes Research Network. That's a mouthful. It's also known as ACORN. ACORN includes nearly 500 practices throughout the Commonwealth of Virginia. And their research is to make sure that everyone gets the right care at the right time to keep them healthy. He was the immediate past chair of the U.S. Preventive Services Task Force, which makes the prevention guidelines for the nation, and was deeply involved with the recommendations for lung cancer screening and for smoking cessation counseling. This presentation will be recorded and will be added to the Integrative Health page of Massey Cancer Center's website. Those of you who have joined us today will be muted during the presentation, but if you have questions, please type them in the chat function. Join me now as we hear first from Dr. Hayes and then Dr. Krist.
Thank you so much, Dr. Chandler, for that lovely introduction. And like she says, I am very honored and pleased to be here with my colleague, Dr. Krist, talking about a topic that's really important, especially during November, Lung Cancer Screening and Lung Cancer Awareness Month. What we're going to do today is I'm first going to talk a little bit about some background information about nicotine addiction, and then a little bit about why do we smoke. And then we will play the video or watch the video together on the Black Lives, Black Lungs, which really gets at specifically smoking and how the African American population was specifically targeted for smoking and continued smoking. And then later we'll have Dr. Krist talk about lung cancer screening and areas around disparities, potential disparities around that. And then I will finish up with how do we what can we do about our smoking? Okay, so let's start it. All right, so I think we all know that smoking harms nearly every organ in the body, which leads to premature death. As you can see here, it nearly does impact nearly all cancers, particularly lung cancer, and many different chronic diseases. What's important for us to know is that this number of 400 to 500,000 deaths per year in the US hasn't really changed. The impact of smoking on our health hasn't really changed so much. We do also have to understand with regards to cancer that smoking does cause 1 out of every 3 cancer deaths. For African Americans, tobacco use in particular is a major contributor to 3 of the leading causes of death among African Americans, and that is, I believe, heart disease, cancer, and stroke. And this graph here just kind of shows a picture of how tobacco use is a main contributor to lung cancer, main cause of lung cancer. Essentially, what we know is that the longer you smoke and the more you smoke increases your risk of having lung cancer and mortality from lung cancer. I do want to point out that although far less people are smoking 2 packs per day or 40 cigarettes per day, still the increase to lung cancer increases even if you're smoking a fewer number of cigarettes per day. And this is very important for the African American population to know about, because African Americans typically smoke less per day than the Caucasian population. Over here to the right, I'm just pointing out that with regard to lung cancer, nearly 80 to 85% of those with lung cancer are former or current smokers. Yet despite what we know about lung cancer and the effects of smoking and lung cancer and other health diseases, 34 million American adults still smoke currently. However, it's important for us to know, and as we'll talk about today, that disparities do exist in tobacco use and in access to treatment that contribute to these health outcomes. For example, you can see here to the right that the prevalence of smoking cigarettes now differs by racial groups. So actually, American Indian and Alaska Native have the highest smoking rates. And this other non-Hispanic refers to multiracial groups, which do include African Americans as well. Among Blacks, currently right now, when we're talking about cigarette smoking, almost 15% of the adult population is still smoking cigarettes. With regard to disparities, part of the concern for African Americans maybe have to do with menthol cigarettes in itself, which is potentially a contributory to addiction and continued cigarette use. And we'll learn about that in the video. So, why do we smoke? Well, smoking is not a bad habit. It is important for us to know that it is a chronic medical condition. And I just want to go over what is an addiction and nicotine dependence. Well, as we've said, it's a chronic disease of the brain where there is an inability to consistently stop smoking, difficulty controlling behavior. It's characterized by having cravings, having poor emotional responses, continued use despite negative consequences, changes in the brain structure and function, and periods of relapse and remission. So just briefly to go over why do we smoke? Well, this is a chronic medical condition. And part of the concern here is that when we smoke cigarettes, we are getting nicotine into the brain. And what happens is that we are impacting a nice chemical in the brain called dopamine. Dopamine is the neurotransmitter in the brain that makes us feel good. It's also involved in motivation, movement, and just overall well-being. But what happens is when we smoke cigarettes, like I said, nicotine enters the brain. And this nicotine kind of unlocks a receptor in the brain that pushes out dopamine that in turn makes us feel good. So the more we smoke, the more we feel good. And that response is greater than the response we would normally get from, say, food. Food is something else that pushes out dopamine in the brain naturally. So over time, this system gets hijacked by nicotine in cigarettes or in tobacco. And in fact, it takes only 7 to 10 seconds for nicotine to reach the brain. And what we know is that the faster nicotine reaches the brain, or the faster that dopamine is released into the brain, the greater potential for addiction. And in fact, when we look at other drugs of addiction, nicotine actually affects more people worldwide than other drugs of addiction. But essentially all drugs of addiction work basically the same, that pushing out dopamine. So why do we smoke? To make it very simple and just for us to understand, nicotine does make us feel good. It does improve our thinking, alertness, memory, concentration, decreases tension, anxiety, and our appetite. It promotes that feeling of well-being. So likewise, it's going to be difficult for any person to want to quit smoking. So now that we've talked about a little bit about the biological role of nicotine, I want to just mention a little bit about the role of tobacco marketing on why we smoke. So in the past, when it was easier to make cigarettes and distribute them, tobacco companies had to figure out a way, how do we get more people to use? And so these are some examples of some of the campaigns and ads that were used. And they actually hired doctors, or not real doctors actually, to make claims about the health benefits of smoking cigarettes. And of course, this was targeted to certain subpopulations, including women. So you can see here, these older ads kind of depict women who smoke with beauty and brains and fashion. Similar things were done for men, in that men who smoke are manly, cool, and attractive to women. Sadly, this was also a ploy for kids. And I just want to point out that we do have some of the quotes from tobacco companies. And so these quotes here that you can see here, I'll read one. Today's teenager is tomorrow's potential regular customer, and the overwhelming majority of smokers first begin to smoke while still in their teens. This is something that our tobacco companies had written in their old tobacco documents, so suggesting that they knew that they needed to market teens in order to get future cigarette users. And I kid you not, this is an actual video of the Flintstones. You can go online and watch that 30-second video of the Flintstones smoking cigarettes here. Now, with regard to African Americans, the tobacco company specifically marketed them as well, and under the what I call the menthol plan. And the thought is that if we market menthol, and you could see that some other tobacco companies here are stating that menthol has a cooling effect, which alleviates nicotine's irritating effect. Menthol masks the taste of tobacco. But what we know nowadays, what's really going on is that menthol boosts nicotine's effect on the brain. It actually masks the harsh tobacco flavor and so are easier to smoke, thus making it easier to start and harder to quit. And that's what we're going to learn a little bit more about in the video, Black Lives, Black Lungs. Just before we get to that, I do want to say that tobacco marketing is helped by money. The four major cigarette US companies have spent $7.62 billion on cigarette advertising and promotion in 2019. They also do things like pay retailers and wholesalers pay incentives and monies to market specifically and to have them out inside and outside of their storefronts as well. We should also know, and this is a whole other topic, but there's been a lot of research to suggest that in more predominantly Black neighborhoods, up to 10 times, there are going to be 10 times more likely to display tobacco ads inside and outside of those retail storefronts compared to less Black neighborhoods or less populated Black neighborhoods. And that is still going on now and still even here in Virginia, unfortunately. So Dr. Krist, do you have anything to add to that? If not, we can go to our video.
No, that's a perfect setup and outlines kind of the scope of what we're trying to address today.
Okay.
Thank you, Dr. Hayes. We'd love to see your kitten.
I'm sorry, you can hear her.
It's adorable. Okay, I'm coming. Oh no.
Hold on, guys, sorry. Yeah, okay, here we go. Where is it? There it is.
There it is.
Okay.
3 years ago, I accepted an internship with Truth Initiative. At the time, I thought I knew everything I needed to know about tobacco. Yes, it could be deadly, but my generation was rejecting it in much larger numbers. But what I knew was just the beginning. Today, tobacco-related diseases are still the #1 cause of death in the African American community, and that's not a coincidence. During my time with Truth Initiative, I read dozens of research articles and stacks of internal documents directly from tobacco industry files. I learned that the tobacco industry strategically and successfully infiltrated my community. And while it's true that they targeted many groups, the targeting of the Black community has been uniquely damaging.
Critics charge that the tobacco companies view Black smokers as a growing source of income. In fact, they say, Blacks are the target of carefully plotted and highly specific marketing campaigns.
For decades, the tobacco companies have used predatory practices aimed to push their deadly product onto the Black community. Practices that contribute to the approximately 45,000 Black people who will die every year from tobacco-related diseases. This film, Black Lives, Black Lungs, is part of my effort to turn my anger into action. I've set out to give voice to some of the experts and activists who've spent their lives taking on the tobacco industry, because understanding the history of this 50-year-plus campaign is critical for taking back the health of our community.
In high school, I became involved in tobacco control because my uncle passed away from tobacco-related diseases, and I remember him telling me when I was younger that when he first started, it was because the industry told him it would cure his asthma. And if you were to hear that statement today, you would think that's the most ludicrous thing you've ever heard. And I just felt like it was so unfair for an industry to be able to target someone like my uncle and have him die as a result. If he had known the real health effects from the get-go, he would have never picked it up. I lost my uncle to an industry who does not care about him, who does not care about the Black body. And I feel I have a responsibility to speak out against it.
Addiction is about brain chemistry, and it's about access. It's not about personal weakness. It's not about poor Black people just are going to do something anyway. It's about that you give this entity access to the brains of your children, of your people, and they become addicted.
There's nothing inherently Black about menthol cigarettes. They were invented in 1925 by Lloyd Spud Hughes. Spud created his own brand, Spud brand, which were the first widely sold menthol cigarettes in the United States. In 1932, Brown & Williamson Tobacco launched its own menthol brand, Cool. And in 1956, industry behemoth R.J. Reynolds introduced Salem, the first menthol cigarette with a filter tip. R.J. Reynolds marketed Salem as fresher, cool, and refreshing. Of course, all without any scientific proof.
Salem's special paper breathes in fresh air with every puff.
The death rates for African Americans who smoke hover around 49,000 per year. It's no accident that African Americans smoke more menthol cigarettes.
One of the greatest marketing coups that took place in the 20th century is transforming menthol cigarette to a Black cigarette. The African Americanization of menthol cigarettes in the United States starts with finding a specialty product for African Americans following World War II. Many African Americans had moved to the North. There were specialty products being developed for them, certain hair creams, certain foodstuffs, and the tobacco industry, particularly some of them, began to realize we could market a particular brand to this group of people. Brown & Williamson conducted a number of focus groups in the late 50s and early 60s that identified that African Americans were more receptive to TV commercials, more receptive to the messages that are provided there. Brown & Williamson then took 90% of their budget and put it into television advertising because they knew African Americans would disproportionately look at that. They began to use Black images on television and in their ads. In 1953, 5% of African Americans used menthol products compared to 3% for whites. By 1968, that had tripled to 14%. By 1976, it had tripled again to over 42%. Into the 2000s, we're above 80%. That's the African Americanization of menthol cigarettes in the United States. It's the targeted marketing over a half a century toward black folks.
Let's dig in a little bit deeper and talk about how African Americans are disproportionately burdened by death and disease from tobacco, cigars, and cigarillos. When it comes to understanding it as a public health issue, I didn't know about that, or a social justice issue in particular, until I started working with TRDRP and Truth Initiative. I didn't understand that the industry had been targeting my community.
In the middle of Jim Crow, there's a civil rights battle going on, and the tobacco industry is way past that. They've got Elston Howard, captured from the New York Yankees, black man selling cool cigarettes. They have executives in their offices in North Carolina that they're, promoting while black folks can't even get a job or sit at a lunch counter. So they're way ahead of the curve.
In 1971, the Public Health Cigarette Smoking Act banned the advertising of cigarettes on TV and radio.
The tobacco industry was one of the first industries to recognize not all marketing needs to go toward white males. So it was good to see black people in the ads and to see that there were black models and that it wasn't all drugs and gangs. And so it was hard. People saw that and they were very much attracted to that.
For decades, the tobacco industry has infiltrated the black community, infiltrated black institutions. In return, what the black community got was death and disease.
We know the facts. We have the scientific knowledge that tells us that we die in larger numbers. If people stopped smoking, if people resisted using these products, it's a preventable disease. We wouldn't have to die in such large numbers. Why do some things still happen in society that we know are wrong? It's all tied to money. Why is the tobacco industry able to sell a product that will definitely, undoubtedly kill you? Because there's money tied to it. And money makes things happen.
I found myself very touched and even upset over what I was seeing, because I saw lists of organizations that included organizations that I grew up in, organizations that I was currently a member of, and I had no idea that behind the scenes there were negotiations between the leaders of these organizations and tobacco companies where they were accepting money and sponsorships.
So in the summer of 1984, I was in my preventive medicine residency at Johns Hopkins. I was doing internships around the country. And so one of the organizations I did an internship was with the Congressional Black Caucus Foundation. While I was there, I was very concerned about the relationship between the CBCF and the tobacco industry. So I started talking to other interns who were there, and then also my supervisors, to sort of see, what can be done. Is it possible to do something from the inside? Because I knew that the effect that it was having on African Americans in general. And so what they suggested was that I write a memo to the executive director. So the memorandum reads, I am very much disturbed by the Congressional Black Caucus Foundation's policy of promoting cigarette smoking. I am especially disturbed at the free distribution of cigarettes at CBCF functions. I am requesting that you raise these issues at the CBCF Policy Board in the hope that we will adopt a policy more in line with our interest in the well-being of Black Americans. And that's how it begins.
Unfortunately, somewhere in the neighborhood of 90% of all African American civil, religious, political, social organizations take money from the tobacco industry. That's just because we ain't got no money. They're buying the silence of these people. The Congressional Black Caucus is a multi-million-dollar foundation, and last time I looked, at least half of their members take money from the tobacco industry. Now, not all of them do, and we tried to work, of course, with the ones that don't, like Karen Bass from Los Angeles and Barbara Lee from up here, Alma Adams in North Carolina. But it's a hard sell, and it's still a hard push to get groups to speak up against the tobacco industry.
The tobacco industry has a very interesting and highly complex relationship with African Americans. Yes, the tobacco industry was the first, or among the first industries to give African Americans high-level executive jobs. They fund several Black scholarships, including the Thurgood Marshall Fund. They funded major civil rights organizations, including the NAACP, the National Urban League, the Congress of Racial Equality, and much more. They did give people in the entertainment industry their first leg up. But you can give me everything in the world, but at the end of the day, what is this industry doing? 47,000 African Americans a year die as a result of tobacco-related diseases. That is the leading cause of death in the African American community. There's not enough shiny trinkets in the world that you can give me in exchange for my life. There's not enough shiny trinkets in the world that you could give me in exchange for my brother's life, for my sister's life. It doesn't matter how much money you pump into the community, we are worth so much more. In my experience, people have been shocked to learn that, they fund so much, that their dollars reach so far. But I think that it needs to be known.
I'm sitting at my desk one day in 1998 when the Surgeon General's report comes out, first report on racial and ethnic minorities and smoking, and it just kind of slapped me in the face that African Americans were dying disproportionately of tobacco-related diseases across the board.
I was actually one of the first to start looking at what the industry had written in their own words about their plans to market their products to African American communities and looking at their relationship building with African American organizations and organizations that I was currently a member of, and I had no idea that behind the scenes there were negotiations between the leaders of these organizations and tobacco companies where they were accepting money and sponsorships. Tobacco-related diseases was really, I saw a main cause for the health disparities that were affecting my community. I couldn't turn my back on this. I just couldn't. One of my colleagues actually saw me crying at my desk at UC San Francisco because I was just so upset over what I was seeing, and she asked a question. I wonder if others in your community would have this kind of reaction to these documents. We then got funding to do another project where we took the documents to groups of African American smokers and young people, elderly people in the community to find out if they would have a similar reaction. And it was very clear that this was information that they didn't have, that they wanted it, that they wished that they had had prior to them picking up a cigarette.
I work with the group, the African American Tobacco Control Leadership Council. Our tagline is Saving Black Lives, and that at bottom it is a social justice question. You might look at it this way: when you have the tobacco industry targeting of African Americans, disproportionately advertising in our communities, giving away free samples, menthol products are less expensive in the African American community. It's a classic definition of a social justice issue where there is a major player taking advantage of a lesser person. Now, there has been some changes. The National NAACP passed a resolution at their July convention saying that chapters could support local and state resolutions to curb or regulate menthol. This is a major breakthrough.
The legislation I'm signing today represents change that's been decades in the making. Today, thanks to the work of Democrats and Republicans, healthcare and consumer advocates, the decades-long effort to protect our children from the harmful effects of tobacco has emerged victorious. Today, change has come.
It's always been an uphill battle. Look at the black folks who fought to set up the Underground Railroad. Look at the black folks who fought Jim Crow. If we're going to fight this, then you're in it for the long haul.
Our communities are under great stress, so we need healthier lifestyles, but we don't need people dumping this poison in our neighborhoods.
If you know someone who smokes who's black, they probably smoke menthol cigarettes. Tell their story.
I think when it comes to just
living as an African American, understanding that just because of who we are, our lives are constantly at threat, whether it is racial injustice, police brutality, being denied access to things. All of these issues are layered and connected.
I made a decision at 18 that I was going to fight back, and I am 67. I continue that fight.
Black Lives Matter, hands up, don't shoot. I can't breathe. I think we're all answering the same question. What is the worth of a Black body in the United States of America?
Dr. Krist.
Thank you, Kathy. And that's a powerful video, and I think it's really important, the justice and equity issues that it brings up. And, leading into this, Dr. Hayes shared with us, how harmful smoking is. And hearing the different targeted campaigns, we can see how this can really perpetuate inequities in health and well-being. For this next part of our talk, we're going to move into some more positive areas of different things that people can do to take control of their health and their health and their friends and their family's health. And I'll invite you, as you're listening, feel free to type questions into the chat, and Dr. Hayes and I will try to address these as we go. As mentioned at the beginning, I'm going to talk some about screening for lung cancer. So smoking does cause all kinds of problems. The number one thing people die from who smoke is cardiovascular disease. But in terms of, and it causes all different cancers, but lung cancer is a very unique cancer caused by smoking. And the positive news is that for people who are still suffering from smoking and trying to struggle to quit, or people who have smoked for many years, there are some things that we can do to help improve health, and we're going to talk about that here. So as we heard, lung cancer is important. It's the number one cancer killer of men and women in America. In fact, more people die of lung cancer every year than breast, prostate, and colon cancer combined. And we hear a lot about screening for breast, prostate, and colon cancer. We don't hear as much about screening for lung cancer. And if more people are dying from this and the other cancers, this is probably something we should focus in on. So there'll be 228,000 people, or actually there were 228,000 people diagnosed with lung cancer in 2020. 136,000 people died from lung cancer. And as Dr. Hayes was saying, somewhere between 80–90% of lung cancers are tobacco related. So for folks who are smoking, if you can quit, it's actually the best way you can protect yourself from lung cancer. And we'll move to that part of the talk after the screening part here. So the two biggest risk factors for lung cancer are smoking and age. So the more we smoke, as we saw with those graphs, the more likely we are to get lung cancer. And as we age, the more likely we are to get lung cancer. Thinking about the equity issue, we heard that there are inequities around promoting and advocating, or promoting and marketing tobacco products. And this has resulted in Black men in America having a higher incidence of lung cancer than white men. And that means they're more likely to die from lung cancer. And Black women having a lower incidence of lung cancer than white women, but they do have a higher incidence of lung cancer than other races as well. So there is this inequity here that we're seeing around the adverse effects from smoking in lung cancer. There are other risk factors for lung cancer. So environmental exposures, prior radiation, lung disease like COPD or emphysema, and a family history. All of those things increases a person's risk for lung cancer. Now, I want to talk for a second about just thinking about guidelines and what we should or shouldn't do for keeping ourselves healthy. So there's this group called the U.S. Preventive Services Task Force, and I had the privilege of serving on this from 2014 to 2021. That makes recommendations for the nation about preventive services. So it's 16 members. They're independent and volunteer, and they're supposed to be experts in prevention and evidence-based medicine. And every year they make about and update about 15 to 20 recommendations. They have about 87 different recommendations across different topics that include screening tests, counseling, and preventive medicines. And these recommendations are supposed to be based on, well, what does the evidence say? What do we know helps people to live longer and to live better? And what should we say they should routinely be getting to stay healthy? And one of these is lung cancer screening. I pressed the wrong arrow. So in 2021, the U.S. Preventive Services Task Force updated a lung cancer screening recommendation. Its first one was actually in 2013. So in 2013, it was recommended that people who smoke get lung cancer screening, but it was updated and changed a little this past year. So right now, the task force is recommending an annual screening for lung cancer with a test called a low-dose CT scan. And this is for any adult age 50 to 80 years who has a 20-pack year history of smoking or more, and who currently smokes or quit within the last 15 years, and who can tolerate curative surgery. So we'll talk about what that means here in a second. But this is a lot of people. It's actually about 14 million people in America are eligible for this life-saving screening test. So this is the test. It's a CAT scan like any other test. It takes about 1 to 2 minutes. It's a low-dose CAT scan, so it's not your traditional CAT scan, and it's looking at the lungs, just the lungs for early signs of lung cancer. It's not a chest x-ray. That's not an adequate test. It's only this low-dose CT scan of the chest. So how does screening work? So right now, only about 17% of lung cancers that are not found through screening are localized, meaning that they're just in the lungs. And what that means is that people who are diagnosed with lung cancer, they've got about a 20% chance of living 5 years. Now, we also know that if we find the cancer early before it's left the lungs, that the 5-year survival jumps from 20% to 60%. So that CAT scan is looking for these early stage 1 and 2 non-small cell lung cancers. That's the type of lung cancer caused by smoking, and it's the type of lung cancer that we can cure. And if someone's found to have this, what the treatment is to remove the lung cancer. So that's a surgery that someone would undergo to remove part of the lung where the cancer is before it can spread and kill people. And there's been several trials, but 2 big studies, one in the United States and one in Europe, that showed that by doing this screening test will reduce deaths from lung cancer by about 20 to 25%. And that means that every 45 people that we screen will prevent one of them from dying from lung cancer. So this is a really valuable and important screening test. Now, it also does have some harms, and everything with prevention has pluses and minuses. The harms from this one is you get radiation. So the radiation from the CAT scan is about similar to the radiation you get just living a year of your life. So if you get one of these CAT scans every year, you're doubling your lifetime exposure to radiation. And that means that for about every 13 lung cancer deaths we prevent, it'll actually cause one other radiation-induced cancer, but it's saving more lives than it's hurting. The other thing is there's false positives. So about 1 in 3 people have an abnormal lung CT scan. And you can imagine people who've been smoking 20 or 30 or 40 pack years, you know, they've done some damage to their lungs, and that's why we see these abnormal findings. And now the good news is that we can apply some logic to these CAT scans to kind of say, well, which ones matter and which ones don't. So not everyone who has an abnormal CAT scan needs to have surgery or a biopsy or treatment. There's some ways to follow some of these so we can figure out which one of these lung findings matters and which ones don't. There's also overdiagnosis. So some of these lung cancers we find a person would never know if we looked, unless we looked. But that's relatively small of these. And there's some anxiety. So if you're told that there's something abnormal in your lungs, that can be a little bit concerning, but something that you can work with your doctor on. And then there's also findings outside of the lungs. So at the beginning, Dr. Hayes said that smoking damages other parts of your body. So it does affect these other parts. And we do see this where people will have calcium in their coronary arteries, or aneurysms or emphysema or non-pulmonary nodules. And those are things that may or may not matter that we pay attention to. And what all this means is that on the whole, the U.S. Preventive Services Task Force thought that this was a beneficial test and this helps people. As I said, 1 out of every 45 people screened won't die from lung cancer because of this. But because of some of these downsides, it means people should talk with their doctor about whether getting screened is right for them. So if you smoke or you know someone who does, and you're wondering, is screening right for me? What I would say is go talk to your doctor. And what your doctor would want to do is to make sure you're healthy enough for screening, kind of talk with you about the seriousness of lung cancer, make sure you understand what this CT scan is, make sure you have a chance to kind of weigh your values, like how worried are you about lung cancer versus some of these potential harms from screening, and then participate in deciding if screening is right for you at the level that you want. Now, there's also good news here with the Affordable Care Act that was in 2014. One of the mandates here is that any recommendation from the U.S. Preventive Services Task Force that gets an A or a B, means to recommend to routinely do it, means that it needs to be covered by health insurance. And it needs to be covered with what's called first dollar coverage. So this means that these tests are often paid for without any copay or any cost to people. So if you think this might be a good screening test for you, like I said, talk with your doctor about whether it's right for you. Now, how are we doing as a nation with screening? As I just said, it kills more people than colon, prostate, and breast combined. And there are 14 million adults eligible for screening. But sadly, here in America right now, only about 15% of people who should be screened are actually getting screened. On the right's a little bit of a graphic of some trends that we've been following over the years of some health systems at Virginia Commonwealth University and some things in Northern Virginia. And you can see screening rates range from about 10 to 20%. Over time, VCU has been really working hard to try and promote screening, and you can see that's going up. But in some other health systems, it hasn't gone up as much. So this is something where I would say really think about talking with your primary care doctor about whether screening's right for you. So we started this segment out talking about equity and that smoking has been preferentially marketed to Black people, and so they're more likely to suffer harms from this. And as I mentioned, we see this with lung cancer. The other interesting thing we see is that Black people have a higher risk of lung cancer with less smoking than white people. That might partly be due to the menthol cigarettes that we saw, but it's not just that. There's lots of other factors. And whenever the U.S. Preventive Services Task Force starts to make a recommendation, we always start by looking and saying who's most likely to suffer from these different conditions and see if we should make different recommendations. And one of the things that happened is from 2013 to 2021, we started recommending screening at a younger age, 50 instead of 55, and lower PAC years. And that has helped to close some of the inequity between the diagnosis of lung cancer in Black people versus white people. So with the 2013 recommendation, if you look at Black people diagnosed with lung cancer, only 32% would have met screening criteria per our old guidelines. Who are Black, and 56% of people who are white. Now that gap closed some with the new changes, but there's still these inequities that also exist. And so that actually leads nicely to Dr. Hayes's talk here about quitting smoking, because I think that's really essential here. So I'm going to stop now and turn things over to Dr. Hayes, but just end with saying that if you think you might be eligible for screening, talk with your doctor about whether it's right for you.
Excellent. Thank you, Dr. Krist, for that. And what I'm going to talk about fairly quickly here is how do we quit smoking? And I just want to add that the video we watched is a couple of years old now. And it was actually in this year, in April of 2021, same time that these new guidelines came out, that the FDA did announce its plans to propose new tobacco product standards within the next year to ban menthol as a flavor for cigarettes and cigars. We don't know exactly how that looks yet. Time will tell, but it is another step in the right direction. And as Dr. Krist was saying, another step in the right direction is to quit smoking cigarettes, any tobacco product actually. And I really want us to think about how do we do that today? I'm going to give us some quick tips on that. First thing is to recognize that it's never too late to quit using tobacco, even after any cancer diagnosis. There are so many benefits of quitting smoking. Just within 20 minutes, your blood pressure is going to return to normal. After 24 hours, your risk of having a heart attack is going to be reduced. And after a year, your risk of developing heart disease is going to be reduced by 50%. It's really important for each of us who are interested, or maybe not so interested in quitting smoking or reducing right now, to think about what are your reasons. Maybe health is not one of those reasons, but there must be a reason. And I would encourage everyone who I work with clinically to think about what are your personal reasons for wanting to quit. So what I like to tell as a clinician here, what I like to share with folks in helping them to quit smoking is this acronym START. Let's start. So the S starts for setting a quit date. A quit date, even if you're not ready to quit, that's okay. Just by reducing or slowly cutting down on how much you smoke daily is going to be helpful to you. But if you can think of a quit date, it's a good thing to think of and plan on what your quit date is and make a plan around that quit date. You do want to choose a day that you'll be preoccupied with. Something to think about is to not have it be an already stressful day, so make sure it's a relaxing or a structured day, and get rid of get rid of any reminders of smoking around you and tell your friends and family. Actually, the T stands for tell your friends and families and other people that you're quitting or at a certain date or around that time. And here are just some tips for how to ask family and friends for help. If they smoke, ask them to try to quit with you. When you feel like smoking, ask them to help you focus on your reasons, your personal reasons for quitting. Ask them to always focus on what you've accomplished, not your setbacks. Sometimes family members can be very difficult and may nag you to, oh, you're smoking again. And sometimes we have to train our family members to ask for, give me some support here. This is difficult. Other things you could do when you're telling family and friends that you're going to quit is, offer to practice relaxing together. Ask them to help you plan how to deal with urges. Ask them how to plan how to celebrate when you quit. The A stands for anticipate your challenges. And so this really gets at knowing what are your triggers. Triggers are things like people, places, things, situations, time, and feelings. Each of these things or a combination of them is going to make every one of us want to smoke or have an urge. Some examples include being bored, drinking alcohol, or even seeing a marketing message on TV. In general, what you want to do is change your behavior and change your thinking. And that's easier to say than do. And that's where getting support and help from your doctor or therapist is helpful. I do want to say that inevitably, the longer you've smoked, you will have some urges or cravings to reuse or to use that nicotine. Just biologically, it's a normal part of the addiction. And pharmacotherapy does double the rates of cessation. So it is something that we do stress, and it is evidence-based guidelines to use pharmacotherapy and behavioral counseling. So in case we're not familiar, there are different types of pharmacotherapy. There's nicotine replacement, which we are replacing, instead of you getting the nicotine from a cigarette, we're replacing it with nicotine from an FDA-approved medication. That's the patch, gum, nasal spray, inhaler, and lozenge. And then there's non-nicotine treatments, Zyban or Chantix. The things that I have here are prescription. You need a prescription, and definitely your doctor will be able to prescribe and help you figure out which is the best medication for you. I do want to say, and we all need to know this, that the combination of pharmacotherapy plus counseling is the best approach to quitting successfully. And when that is happening, a person is going to be 2 to 4 times more effective than quitting cold turkey. So just a little bit about e-cigs, because I know a lot of people who are using e-cigs may use them for harm reduction or to quit cigarettes, but it's important to understand that e-cigs are not harmless. Although they may be safer than using cigarettes, the vapor from the e-cig still can contain harmful chemicals that can irritate your lungs. It's also important to know that the FDA has not approved e-cigs for cessation here, and we do not know the long-term health effects of e-cigs. The best information is to use FDA-approved quitting aids like the nicotine replacement or the non-nicotine replacement aids that have been found to be helpful to help people quit smoking and that are approved by the FDA. If, however, you are trying to use e-cigs to help you quit smoking, it is best to switch completely and also have a plan to quit e-cigs completely. So just quickly, what are some other resources out there to help you quit? Our telephone quit line is evidence-based and is great. It is available 24/7. It is free. Here's the number, 1-800-QUIT-NOW for our Virginia quit line. And the counselors are trained and they're ready and willing to hear from you and design a personalized quit plan for you. We also have text messaging. Really, essentially on this slide, just text QUIT to 47848, and you will have access to a free text messaging method where you can quit or opt out at any time. The counselors will send you texts that last about 6 to 8 weeks, depending on your smoking status, and you'll receive messages daily, tips and advice for smoking cessation or harm reduction. Locally in Richmond, Virginia, Richmond City, if you live in the city, there is a program to assist you, and you may also be eligible for free nicotine replacement therapy. Maybe our slides will be available, that you'll call this number here and reach one of the coaches. The coaches themselves have quit smoking and are peer counselors, so it's been a great program lately here in the city. And of course, if you're an internet person, you can go to smokefree.gov, which has a lot of resources, has a support network, has a lot of handouts for all different types of smokers. Here's just some other resources, Smoke Free, the American Lung Association, and Become an X are also important resources to consider. And I just want to put a plug out, talk to your healthcare professional or any clinician or your doctors. Ask them to talk to you about your use of any tobacco product, not just cigarettes. And I just listed here some questions to ask about cigarette smoking and quitting with your doctor. Sometimes just kind of reminding your physician to tell you a little bit more about the best products for you to quit can be helpful, and help them remind them to talk to you about smoking and refer you to evidence-based treatments like a counselor or the quit line or pharmacotherapy. If you just ask them, hey, can we spend a little more time about talking about my health and how it's impacted by smoking, I'm sure all of our physicians are going to want to oblige and answer your questions. And even just asking them, can you bring up my tobacco use at our next visit to help me progress with my goals? Sometimes when we're making behavior change, it is great to have that other person to help with some accountability. And I think all of this stuff is really useful, particularly for African Americans, because we know that 74% of African American adults want to quit a year, and about 60% do attempt to quit each year. Unfortunately, the success rate of quitting among African Americans is 3.3%. That's not too different from other ethnic groups. We know that our treatment does work just as well for African Americans and for other ethnic groups. The concern is, are we reaching, are folks wanting to quit, are people getting that access? And so I think it's a great opportunity to know these resources through lung cancer screening, through the city of Richmond, and in your local hospital system about resources to quit, because it is very possible. Okay, so what should you do now that we're at the end of our presentation? Well, remember to start, remember those steps, and then I would recommend talking to your physician or clinician doctor. Write out your list of reasons why you want to do this. Why do you want to change your behavior? Think about those strategies to cope with any triggers that you have to smoke. And importantly, think about how you reward yourself for not smoking, especially within that first 4 to 6 weeks. And lastly, I always end this by saying, congratulate yourself for making the change. Congratulate yourself for listening or referring this presentation to your loved one. Is a great thing to kind of help you with your next step. So that's all that I have. And, I think Dr. Krist, we can open it up at the end here for a couple of questions, comments.
There had been one question in the comments that I saw about would people exposed to secondhand smoke be eligible for lung cancer screening? And I'll just say that the U.S. Preventive Services Task Force was really focused on people who smoked, and based on their age. We couldn't actually find data and studies about secondhand smoke exposure, so it's not part of the guideline. I would say if you're worried and you feel like you have a large secondhand exposure and you think it'd be similar to a 20-pack year history of smoking yourself, talk with your doctor about what's right for you and would that be something to do. And of course, if you have symptoms, to talk with someone about that. And Dr. Hayes, I loved everything you presented on quitting smoking. The other fact I often say with my patients that you were highlighting in there is I say that the average person who quit smoking had to try 7 times before they were successful. So I try to use that as a little encouragement to my patients who say, oh, doc, I've tried to quit smoking and it didn't work. And that's okay. Every time's a new time and it might work the next time. So
we're always learning something from that previous time. Yeah.
There was a question about what a 20-pack year history of smoking is. So as Dr. Hayes showed at the beginning, 1 pack is about 20 cigarettes. So 20-pack year means that on average you smoke 1 pack of cigarettes per day for 20 years. So a person who does a half a pack a day for 40 years would have a 20-pack year because it's half a pack for 40 years. But it's sometimes hard to figure out what exactly a pack year is because many people who smoke, some years they smoke more or less at different times. But and as Dr. Hayes was showing on the slides, even if you can cut back on smoking, that's a good thing to do.
Thank you, Dr. Krist and Dr. Hayes. That was an outstanding presentation. And if you would like to see the resources, this presentation, having been recorded, will be placed on the Massey Cancer Center website. So you can go there. It will probably be a few days before it's up on there. So you will have those resources available to you. Thank you again, both of our wonderful speakers, and for the Office of Community Outreach and Collaboration. We are very grateful for your work with this. Thank you.
Thank you.